Dear colleagues, dear patients, today I want to talk about the impact of dysautonomia on physical performance. Our data most of all depends on spirometry data at the University Göttingen measured in patients after surgery of congenital heart disease. We think that the bad physical performance in some patients depends on residual lesions or a bad ventricular function. However, what's obviously wrong. If we saw in the magnetic resonance imaging that the data about right ventricular shape and function, left ventricular function, or the time of the QRS complex didn't have any impact on the maximal oxygen intake or plasma proBNP data. Today we know that the data most of all depends on dysautonomy measured by heart rate variability analysis in the Holter ECG. And this data clearly show that the high frequency power and low frequency power and very low frequency power decrease with decreasing maximum oxygen uptake. And these curve ends at around about 18 milliliter per kilogram per minute. Our most cited paper is this paper. If we show that the heart failure measured by maximum oxygen uptake and BNP values increase with increasing age. Have a look on this nice picture who shows that the tree is blooming despite a bad stenosis after the beavers gnawed on it. We further know from adults with left ventricular dysfunction that the maximal oxygen uptake have an impact on prognosis, like shown in this slide. Above 25 milliliter per kilogram per minute, there's a good survival, but the lower data shows a very bad prognosis in those patients with a bad physical performance. We now analyze our data from Göttingen and the new data from Bad Mergentheim in nearly 100 patients and clearly show high significant correlation between maximal oxygen uptake, body mass index, and most of the heart rate variability parameters. The right and left ventricular function measured by the time index also have a significant correlation with the maximum oxygen uptake. However, after multiple regression, there's only the BMI value, the very low frequency power, and the operation as the age of operation that have a significant impact on maximal oxygen uptake. These data are in good accordance with data measured in adults with left ventricular dysfunction, where the maximal oxygen uptake correlate with age, body mass index, the New York Heart Classification, the NT-proBNP value, and interestingly, the TAPS. This is a echocardiographic parameter of right ventricular function. Looking to all the spirometry data measured in Göttingen and Bad Mergentheim, we have a clear loss of physical performance in patients with congenital heart defects with age. Up to the age of 15 years, there are normal maximum oxygen uptake, and despite the same hemodynamics, the physical performance decrease with increasing age in males and in females. In many patients, we have both the data of the spiroergometry with the maximal oxygen uptake and the heart rate variability measured in the Holter ECG. Looking to patients with after surgery of congenital heart disease, we have the same pictures at the beginning of the talk, the decreasing heart rate variability in all frequency bands with decreasing maximal oxygen uptake. There's another picture in those children with healthy hearts who do not show such a clear impact of heart rate variability on physical performance. There are also different heart rate response at the beginning and the maximal load of the spiroergometry. There are nearly normal heart rates at the beginning of spiroergometry in patients with congenital heart disease, but there are decreasing maximal heart rates with decreasing maximal oxygen uptake, as published first by Up in 2005 with the title of Chronotropic Incompetence in children after surgery of congenital heart disease. Looking to the children with healthy hearts, there are high heart rate at the beginning of spiroergometry in those with low maximal oxygen uptake. Who are these children with healthy hearts who have such high heart rates at the beginning of the spiroergometry? These are the children with the so-called new morbidity, children with obesity, children with attention deficit disorders. These children are the children with high heart rates at rest with very low maximal oxygen uptake. How we can improve the physical performance in patients, for example, with inappropriate sinus tachycardia. We have this data from a publication in adults. We are able to improve physical performance with beta blockers, low-dose propranolol, or ivabradine. There's up to a 25% increase of maximal oxygen uptake by decreasing the heart rate at rest, as shown in these pictures, with lower mean heart rates at day and night and lower heart rates at the beginning and the maximal load in spiroergometry. In my opinion, that is a good way to break the vicious circle of morbidity with those children who have a high caloric intake, inducing higher heart rates at rest and a lower heart rate reserve during spiroergometry. Due to the bad physical performance, those children have low calorie consumption and the body mass index increase. That is one way beneath nutrition and sports to improve the physical performance in these children who have higher heart rates due to new morbidity. Unfortunately, we have no chance to improve physical performance after surgery of congenital heart disease, for example, those with pulmonary valve insufficiency. In our prospective trial, we cannot improve the maximal oxygen uptake with bisoprolol, the beta blocker bisoprolol. The same disappointing result with enalapril, percutaneous pulmonary valve replacements, or surgical pulmonary valve replacement. To understand this complex interaction between dysautonomia and physical performance, we have to look on the normal values measured in many patients. We see the steep increase of heart rate variability up to puberty in children And at the age of 15 years, we have the highest heart rate variability and the highest maximal oxygen uptake. With increasing age, the heart rate variability decrease as well as the maximal oxygen uptake in the superior ergometry. To find an answer to this disappointing results of therapy of bad physical performance in patients after surgery of congenital heart disease, I recently analyzed my whole patient records of the last years. These are 224 patients with operation of congenital heart disease. To understand those analyses, you have to understand the complicated stratification. First, I analyzed the data of the infants according to the therapy, to the standard therapy with diuretic and part. Some patients have ACE inhibitors, or those infants who have additional beta blocker therapy. The next group are the patients without spiroergometry data up to the age around of 9 years. These patient group is stratified by age. And the last group is a group of patients with maximal oxygen uptake data according to physical performance, those with a high physical performance, those with normal physical performance, and those with low physical performance. The data are shown in the next slides. In the first slide, I show the time-domain data of these patients after surgery of congenital heart disease. The normal data are shown as columns, and the patient data is shown as lines. In black, there is a heart rate variability that is nearly normal in all age and person groups, but there is a significant lower heart rate in infants who receive a beta blocker. Looking to the vagus activity shown as RMSSD data in green, we have very low vagus activity in patients, in infants treated with standard therapy that improve with a beta blocker and remains normal up to the age of 10 years and decrease with decreasing maximal oxygen uptake. There is a similar curve of the SDNN data in red, with low data at the beginning and low data in those patients with bad physical performance. In this slide, there are the data of the spectral analyzers with high frequency power, the vagus parameter shown in green columns, the low frequency power in red, and the very low frequency power in gray. Looking to the data with standard therapy in infants, there's a significant lower high frequency power in these infants with severe heart failure. We have to know that 50% of patients who died from congenital heart disease are infants. The reduced high frequency power is one of the best predictors of mortality in this patient group. Congenital heart surgery is the most effective therapy to improve heart failure in these patients. Guideline recommendations for digoxin, ACE inhibitors, and vasodilators are not supported by any prospective randomized trials for more than 50 years. What about the preoperative beta blocker therapy? We clearly show an improvement of heart rate variability and clinics in a prospective randomized trial. Our long-term data in the next slide will show that after beta-blocker therapy in infancy, we measured normal heart rate variability in the long-term follow-up. It has to be proven if preoperative beta-blocker therapy of heart failure improve heart rate variability, maximal oxygen uptake, and outcome after surgery of congenital heart disease. This concept of autonomic imprinting is one of the most innovative concepts to explain long-term prognosis in patients with congenital heart disease. What about the patients who uh, have low physical performance after surgery of congenital heart disease? Maximal oxygen uptake after surgery for congenital heart disease depends on age and heart rate variability. Long-time survival depends on maximal oxygen uptake and heart rate variability. Current therapies with beta blockers, ACE inhibitors, AT1 antagonists, bosentan, and sildenafil didn't improve maximal oxygen uptake and probably heart rate variability that is not measured. Pulmonary valve replacement, the most often performed intervention, didn't improve maximal oxygen uptake and probably heart rate variability. Sports intervention and lower BMI probably improved maximal oxygen uptake and perhaps heart rate variability. Perhaps SGL2 inhibitors improve maximal oxygen uptake and heart rate variability that have urgently been proved. I recently analyzed the heart rate variability of the infants who are treated with propranolol preoperatively. These infants have normal RMSSD values as indicator for normal vagus activity up to the age of 11 years. The same picture is shown in the frequency domain analyzers. Only during standard therapy we have the low high frequency power that improve with propranolol and remains normal up to the year of 11 years. The same data is shown for the low frequency power and very low frequency power. The heart rate indicated as a black line decrease with propranolol and remain nearly normal over the whole time. What we have learned in the last 25 years is that the effect of beta blockers is the best in those infants with early life stress. The propranolol data in infants with severe heart failure clearly show the lower heart rate in white, the better heart rate variability indicated in red, and the impressive better vagus activity indicated as green, the RMSSD values. In the same age, those patients without early life stress, like the infants with hemangioma, have a lesser effect of propranolol on heart rate variability. And adults with congenital heart disease have nearly no improvement of heart rate variability after the treatment with bisoprolol in the prospective randomized trial. What to do with these patients after surgery of congenital heart disease who have such a bad physical performance? There are two cases of patients with pulmonary valve insufficiency after corrective surgery of Fallot tetralogy. On the left side is a boy. I meet him with 16 years. He smokes cigarettes, is very obese, and have a very low heart rate variability. Despite all my wishes to improve his lifestyle, he changed nothing and get aortic valve endocarditis with further bad values of heart rate variability and the low maximal oxygen uptake around 20 milliliter per kilogram per minute. The beta blocker improved nothing. At this time, he decided to a weight loss around 20 kilogram within 3 months. He makes a lot of sports and have a very healthy nutrition. And at this time, without any pharmacological intervention, his heart rate variability improved and his heart rate decreased. Today, 10 years later, is a very successful student and businessman and have a little higher heart rates and a little better um, um, and the heart rate variability is a little bit worse. On the other patient is a woman I meet 5 years ago, and she have decreasing physical performance after COVID-19 infection, after the second infection, despite vaccination. The heart rate variability decreased to very low values, and the physical performance decreased. There are some arrhythmias with premature ventricle contraction that improve with omega-3 fatty acids, but the heart rate variability remains very low. She becomes pregnant, and after birth of the healthy child, the heart rate variability improves significantly and the heart rate decreases to lower values. The physical performance is nearly normal, and these good condition remains for 6 months today. Those who are interested in this concept of autonomic imprinting may read my book about diagnostic and therapy of regulation disorders of the autonomic nervous system in children and adolescents, at this time only written in German. Thank you for your attention.